This is usually the funnest part of these patient conferences, okay? All right, the first question is, what are the common small bowel complications in low-grade NETs, and how does that impact outcome, prognosis? I think that's a great question for our surgeons. Dr. Maluccio, complications of small bowel NET surgery, how does that affect prognosis?
Come on.
Oh, no.
No,
we
are not.
Use these. Use these. Yeah, just leave this here.
This is for the recording.
Yeah.
There's the nerds here. Okay, so I'm pressing this button.
There you go. These.
Okay, can you hear?
Shut it off. Check.
Got it. Check.
I think you just gotta get
Check. Does he like? Oh my God. Check. Like Lady Gaga. So why don't we say the overreaching, regardless of whether or not it is a small bowel versus pancreas versus bronchopulmonary, is that complications related to surgery impact outcome. Now, the degree to which they impact outcome is going to vary on the complexity of the surgery. So that's a sort of a caveat, because I think Dr. Demir and I are going to agree that small bowel resections are probably some of the lowest risk surgeries that we actually do, and so the likelihood of a complication with a small bowel surgery is very low, but the types of complications, like a leak over the suture line where we're putting it back together, can be very consequential. And then in patients with multifocality, small bowel obstructions that involve a huge segment of the bowel, mesenteric ischemia, which is when you lose the blood supply to your small bowel, is that the more gut you lose, then the more likely you're going to have complications with nutritional status, macronutrient deficiencies, short gut syndrome, and although your body is extraordinarily resilient, it does make then it leads to other life-altering things going forward. So the complications of a small bowel surgery are very low. When they happen, they can be consequential, but they are usually not life-limiting. And that depending on the type of case that you are doing, there may be unique challenges related to the surgery that can lead to additional, even more rare complications. Do you know what I mean?
I have nothing to add.
No, I think you got it. That's
Perfect. Nicely summarized. Thank you. All right, let's move on to the next question. Any especially exciting clinical trials and where to find out about these? Actually, my talk is about clinical trials, so if you give us another hour, I will kind of run through the current landscape of exciting clinical trials and how to find them. So we can probably table that question in the afternoon Q&A. Thoughts on genomic therapies for neuroendocrine tumor, Dr. Del Rivero, or maybe we can also broaden it to not just genomic therapies, but genetic testing, role of that in the management of neuroendocrine tumor.
Yes, can you hear me? Okay. I will answer the second question first. It's about genetic testing and which patients with neuroendocrine tumors needs to undergo genetic testing. I think I mentioned earlier on my talk that in terms of neuroendocrine tumors, pancreas neuroendocrine tumors, less than 10% is associated with a familial syndrome. Which familial syndrome are those? Some of the ones Dr. Demir mentioned briefly in his talk as well. One of them is MEN1, multiple endocrine neoplasia type 1. But usually those patients have other clinical manifestations as well. For example, MEN1 has the condition of what we call primary hyperparathyroidism, meaning that there is the parathyroid gland, which is next to the thyroid gland, and they're responsible for the regulation of calcium in the body. And if you have an overactive gland, they're going to start getting all the calcium from the bones into the circulation, and you have very elevated calcium levels, and that's usually the most common manifestation in a patient with MEN1. We also have pancreas neuroendocrine tumors, as well as other pituitary tumors as well. But there are other clinical manifestations associated with this familial syndrome. The other one is the von Lippert-Handel disease.
Hippel-Lindau.
Yeah, VHL. Von Hippel-Lindau, my apologies. Von Hippel-Lindau. And those patients also have other clinical manifestations besides the pancreas neuroendocrine tumors. They have the CNS, central nervous system hemangioblastoma. There are also eyes hemangioblastomas as well. There are other clinical manifestations like kidney cancer too, pheochromocytomas that are more present compared to the pancreas neuroendocrine tumors as well. Usually pancreas neuroendocrine tumors related to von Hippel-Lindau, they can be quite cystic, and not all of them they can metastasize compared to the other tumors. But that said, we follow the same guidelines in terms of size as well, in terms of resection of the pancreas neuroendocrine tumors. We also have other conditions like tuberous sclerosis as well. This is even more rare when patients present with pancreas neuroendocrine tumors, neurofibromatosis as well, type 1, which also may have an association with pancreas neuroendocrine tumors, but NF1 or neurofibromatosis type 1, they have other clinical manifestations associated with the syndrome. What I'm saying with all of this, because it's also a question that I also get from patients that tells me, well, I have these pancreas neuroendocrine tumors, and I just want to make sure that, is not something that I can pass to my kids, and that's usually my answer, less than 10%. But also there's also other clinical manifestations. Usually there is no standardized guidelines that tells me when to do genetic testing. Usually it's not recommended. That said, in my practice, I do, if I have a patient that is in their 20s and 30s, a very relatively young patient, I do want the patients to be seen by genetic counselor. Sometimes what I do, and I don't know how your practice is that when the tumor is resected, I do send the tumor for genetic testing. And sometimes if in the tumor, because we have two type of genomic testing, one is in the tumor, and one is in the blood. So the tumor is only, those mutations are present in the tumor. The other one that is, when we do a testing either in the blood or in the saliva, is to determine whether it's what we call a germline testing, and those are the ones that you can pass to your kids. But sometimes information within the tumor sometimes can guide me whether I can do further genetic testing as well. And that's usually something that I discuss with my genetic counselor. Part of our group at ANH is having a genetic counselor who helped me also understand when and how we can do this type of genetic testing. But overall, as of now, it's not indicated. That some young patients may be indicated as well. So maybe I hope it's a long answer for that question. And in terms of gene therapy for neuroendocrine tumors, there is no any gene therapy for neuroendocrine tumors. Sometimes with these germline testings, they want to modify the gene in order to treat it. But that said, it's not something that we are, that is not done until now. Yeah.
Just a quick comment. There's a really good resource, the American College of Medical Genetics actually publishes guidelines. There's a nice table. Paper's probably 3 or 4 years old, but they update it periodically, and it'll go in there and you'll look, and it's in there's like colon cancer. It's not specific to neuroendocrine, but you'll look and it says parathyroids in somebody underage. I believe it's 30, but a young patient or somebody has a pancreatic neuroendocrine tumor, but also had a pituitary or also had parathyroid, then indicate testing. So I mean, it's just a nice chart. You can kind of look in there that'll summarize, because I don't remember all those things real well, but I keep that article on my desk so I can just refer to it all the time. But yeah, you can Google it, find it, American College of Medical Genetics.
And a small tip, you can always ask your provider, hey doctor, do I need genetic testing? That will always force them to think, do you have those risk factors? Because we don't always remember all of these things. So we also go and Google them. Now, maybe not Google them, but we go to the peer-reviewed paper and we look, okay, do you have these risk factors? Do you have first-degree relative, second-degree relative, personal history of some of these conditions, and kind of stratify. And then if you meet enough high-risk criteria, then we will send you to genetic counselor, okay? So it's always good to ask your provider, hey doc, do I need genetic testing, okay? Good, but most would not need it. Okay.
Mm-hmm.
All right. Next question: what amount of weight loss is common or acceptable in neuroendocrine cancers, and any insights on coming, or recovery from this significant weight loss? Dr. Ganji.
Mm-hmm.
At LA, probably that's a good thing, right? I'm kidding.
Yeah.
They're
Um,
exempted now.
I think that's a difficult question to answer because we typically don't want you losing weight in general secondary to your cancer, right? Sometimes we ask you to lose weight in preparation for surgery or other things to simplify that, so that it's different if it's controlled or uncontrolled or intentional or unintentional. So I'm assuming we're going with unintentional weight loss. If it's related to surgery, then sometimes, as Dr. Maluccio alluded to, sometimes if we have to take a significant proportion of your small bowel, or if there's pancreatic enzymatic deficiency or intolerance of certain types of food, we try to modify that with different medications that we can give you. And ideally, I typically don't want my postoperative patients losing more than 1 to 2 pounds per week, and they should typically stabilize after 2 to 3 weeks. So that to me is concerning if we're not able to manage that. If you're losing weight secondary to the fact that you have pain or PO intolerance and it's pre-surgery, then that again is also concerning. I don't have a specific number. It's just we don't like cancer-related weight loss in general.
Obesity and cancer in particular is really fascinating. If women gain weight after breast cancer surgery, they actually have worse survival. After gastric bypass, the risk of cancer goes down about 30%. And we don't know why all that. Ozempic is really interesting for neuroendocrine, because one of the contraindications is if you have MEN2. It's because in mice they saw C-cell hyperplasia. So if you've had medullary cancer, you don't want to be on one of these GLP agonists like Ozempic. We don't understand all these things, obviously, but the whole question around obesity, weight loss, thin mice live longer than fat mice, and so we don't understand all these things yet, but it's a really important area of research.
I agree, and my thoughts about the weight loss is unanticipated weight loss. It's one of the cardinal symptoms of cancer, regardless of what cancer we're talking about, right? So when we are dealing with a metastatic cancer, these cancers secreting certain chemicals, bad chemicals like cytokines, they trigger a cascade, makes your body go into the breakdown phase, what we call catabolism, right? So our natural tendency is to be anabolic, to kind of grow and build. But the reason why we see one of the symptoms of cancer patients is unanticipated weight loss is because these catabolic pathways are active or hyperactive, and we are in a state of cancer cachexia, okay? With that, having said that, about the traditional number is 10% or more of weight loss, unanticipated weight loss in the last 6 months considered significant, okay? Of course, it varies because the baseline weight of the patient, were they very obese to begin with, etc., and etc., and in what context are we looking at? Sometimes if patient needs a curative surgery, it might be better off that they are not significantly overweight. But that's the usual kind of weight loss that we start getting worried about, unanticipated weight loss, not because you're dieting, you're exercising, etc., etc. So healthy weight loss okay, unanticipated is not okay. I think you have a question. I would encourage people to write the question so we can, but let's go ahead.
Yeah, it was related to that question though. So like following unanticipated, like not okay weight loss, cachexia, all of that, what are sort of the ways that folks would address that or counteract that other than just eat more?
No, that's a great question, and it's not a simple solution. So the underlying root cause of it is cancer. So we need to have a great strategy to figure out what's the best management plan. Of course, the early stage cancer, we heard surgery is the curative resection, right? But if it's a metastatic disease, we need to kind of first have a game plan for how to stop the cancerous process, right? That is part of it. But there's also a lot of things that you have to kind of build back your reserve. So nutrition is really, really important. Unfortunately, we don't have a nutritionist with us today. It's a very common, one of our key members in our multidisciplinary nets program is a nutritionist. So you need to kind of have a discussion with them. They will counsel you on a well-balanced diet, maybe calorie-dense diet, which is filled with nutrition, proteins, macronutrients, etc. So that's part of it. In cancer patients, also the other issue is that why is weight an issue? Is it the absorption? Because if it's a shortcut patient, you might be eating everything that you need to eat, but you're just not absorbing. So that needs to be addressed. Or is it that patient's not hungry? As a part of cancer cachexia, the appetite can be an issue, and we have medicines to help with the appetite. So we need to figure out what is causing the weight. Is it the appetite? Is it the absorption? And we have to tackle the root cause. Any other comments on that?
Can I add a comment here? And yes, as Dr. Chauhan mentioned, all of the causes of weight loss due to cancer, but we also need to look at medications causing decrease in appetite. For example, some of the tyrosine kinase like sunitinib that can also decrease appetite. Everolimus sometimes can also form some ulcers in the mouth, and sometimes patients can be it's quite painful, difficult to eat. On top of that, in a patient with small bowel neuroendocrine tumors having diarrhea and not control properly, that can also, all of that together can certainly cause weight loss. And I think all of that needs to take in consideration as well whenever we see a patient with neuroendocrine tumor that had persistent diarrhea because of the hormone excess, that is undergoing therapy as well, that some of these therapies may also decrease appetite. But like Dr. Chauhan mentioned, there are certain measurements that we can take in order to decrease appetite. And of course, having a nutritionist is very important as well, a consultation with a nutritionist.
All right, hopefully that helped. All right, let's move on to the next question. That's a tough one. That's for Dr. Demure. Alternative therapies. Very common questions we get asked almost every clinic. Any thoughts, suggestions, warnings about alternative therapies?
Yeah, in Southern California, we're well aware of a lot of people out there, doing high dose vitamin C, whatever, all kinds of different, things that are
Stem cell treatment.
all things that are, unproven. What I would say is, you want to go with things that are treated, that have been subjected to prospective randomized clinical trials as much as possible, which is how drugs like sunitinib got approved, capecitabine temozolomide got, good data, Lutathera, the Netter, trials had, good data. So that's proven. A lot of this stuff is not proven, and then, the patients, I think there's people that have that cancer in particular are what I would consider vulnerable to false hope, people preying on that, because these things very often aren't covered by your insurance. You're paying a lot of money for unproven therapies. So just be cautious. If you're going to do it, I would strongly urge you to discuss them with the doctors that you are seeing, because sometimes some of these supplements can have components that will affect the way your medications may be metabolized and may inadvertently cause harm. So even if you are doing some other therapies that in particular that can affect perhaps how you metabolize the drugs that your doctor is giving you, to adverse effect. So those would be my main comments.
Thank you. Dr. Maluccio?
Sorry, if I could make one comment on the difference between alternative therapies and complementary therapies. I think that there are cancer programs that have complementary therapies that are things like the acupressure, things that are to decrease stress, all things that actually add to the burden of managing a cancer diagnosis or recovery from surgery. And then there is now a subspecialty of nutrition that is called integrated nutrition that has the ability to look at a lot of things that may be unique to your situation, other medical problems, like Dr. Demir said, medications that you're on. But I think we're all going to agree that to take an alternative strategy in lieu of the tried and true is just not taking advantage of a lot of the progress that's been made in neuroendocrine over the last probably 20 years.
Great, thank you. Dr. Ganji, this one is for you. How do you track spots that are visible on a dotatate PET, that are dotatate avid, without doing another dotatate scan? Because sometimes insurance don't allow you to do follow-up scans. So how do we track these lesions?
So I think it's dependent on where the lesions are. A lot of the time, but not always, we're able to identify them on a CT or an MRI, depending on what specifically we're looking at. But occasionally there could be very, very tiny lesions that are picked up on a dotatate scan that are otherwise difficult to see. So there's sometimes no perfect way of tracking those lesions on alternate imaging. For example, sometimes peritoneal metastatic disease. So those are tiny, 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 like salt granule type things in the abdomen that you may not frequently don't see on a CT scan or an MRI. There are some enhancing things we could do or request from the imaging department with respect to the MRI or the CT that may allow you to see those. But really, if you think about picking up a grain of salt on a CT scan, you're not always going to see it. But the dotatate can be sensitive enough to pick that up sometimes. So it's not perfect. And in those scenarios, typically we can get a repeat dotatate within a year or so. So it's not it's not ideal, but that is one way to follow. And in the interim, you would get your routine imaging.
Great, thank you. It's a very specific question, and I don't think if I understand the dose here. Can prenatal DES exposure, okay, so hormone exposure cause neuroendocrine cancer, not just the reproductive cancer? Dr. Malucci, you want to take that?
DDS, silvestrol.
Give it to I don't usually have no answer.
Dr. Del Rivero. I should have asked the endocrinologist. That's a misfire.
No, yes, it's DTS. The silvestrol, which is kind of like a precursor of estrogen. But no, it's not. We don't know any association of this medication with neuroendocrine tumor. That's the answer.
In the same vein, do you want to comment about SSRIs and neuroendocrine tumors? That's also another caution, because we see serotonin can be elevated in some NETs patients, and with some of our antidepressants, we are trying to raise the serotonin. So is there any concern that use of antidepressant makes these cancers worse?
Yes, that's a good question, and the answer is no. There has been studies in that sense where patients with neuroendocrine tumors has received different type of SSRIs, and the answer is it doesn't make the carcinoid symptoms or syndrome worse. We published about that as part of NANET's, one of the white papers by NANET's as part of the care in terms of palliative care and hospice care as well, that in those situations, if to address symptoms of anxiety, depression, is important to acknowledge that these medications can be used and is safe as well, and doesn't make the symptoms of carcinoid syndrome worse.
Great, thank you. So, interesting question. This is regarding the dotatate scan. Why do some come with description of liver tumors in 2 lobes, while other, I guess they're alluding to another scan, comes with a description in 3 lobes, and other with description segment 8, for example? Do you see a lot of inter-scan variability in how they're read, and how do you reconcile that, and what is your advice how these lesions should be followed? Open to the panel.
Yeah, it's important that the surgeon looks at the scans, because it's just terminology. The liver, you have basically the right lobe, so right lobe, left lobe. That's if you cut the liver in half. Caudate lobe, if you remember the drawings, a little number 1. It's a small toward the back and along the vena cava, along the main blood vessel. But then, based on blood supply, you can subdivide the liver into 8 subsegments or segments, if you will, and then that guides, as Dr. Ganji said, the surgical resection. So a radiologist that works with liver surgeons quite a bit, sometimes would be more descriptive. in terms of the anatomic things. But it's much like if you're looking at a pancreas tumor. As a surgeon, we look at it a little differently. We're looking for different things. You may look for an abnormal blood vessel to the liver where it doesn't come off the main hepatic artery, but comes off the artery to the intestines. But you need to know that so you don't inadvertently cut that artery when you're doing the resection of the pancreas, or invasion into those two big blood vessels, the big vein and artery that run behind the neck of the pancreas. So surgeons look at the x-rays a little different. I think sometimes that terminology is trying to help the surgeon in terms of the details of what we need to know to do the surgery.
Great. Dr. Liu, you have any other comments?
Oh, yes. So one small comment is about that as surgeons say that they look at scans differently. From the medical oncology perspective, that will be the case as well. And one of the reasons is because me personally, and the same with Dr. Shahan, we like to look at the scans, not necessarily read the report. Because if you do different scans in different centers, and if the radiology doesn't have a comparison, they're just going to name everything that is there, not necessarily having a comparison of another scan if you do in different places. And also happen that the radiologist who's reading the scans maybe haven't looked at the series of scans before the scan that the radiologist is reading. So because of that, they may see some variabilities, but that's important that your primary oncologist also look at the scans. Dr. Shahan, myself, we are used to look at the scans and compare, or talk to the radiologist and compare just to see what is the difference. And often there is really no difference. It's just how the radiologists read the reports and report on the
100% agree. And
Yeah.
that's why we also review the scans in our tumor boards, where we have our radiology colleagues who pull up the scans in a big screen and show us this is what they meant by this description, and then go back in time and compare to the older scans. All right, next question. Any thoughts on everolimus? I'm surprised I haven't heard it mentioned. I can quickly wrap it up. That's why, when you have a surgery dominant panel, I'm just messing. So everolimus is a very important drug in management of neuroendocrine tumor. It's FDA approved. It's actually one of the very few FDA approved drug for NETs, which is approved for all NETs, be it pancreatic, midgut, lung NETs. And the biggest study, or the best study about everolimus was the RADIANT-4 study, which showed that the patients who were treated with everolimus or Afinitor had a stable disease almost for a year, 11.4 months, as compared to the control arm or placebo arm, which was just about 4 months. So the drug works. The drug also gets a little bit of bad press because of side effects, but the key here is to find the right dose for the patient. So I often start with the lower dose and then kind of go up, rather than start on the highest dose and have a lot of mouth ulcers and diarrhea and fatigue. If you optimize the dose well for each patient, most patients would actually be able to tolerate this drug, and it's a very important tool in the management of NETs.
Can I weigh in on that?
Yes.
I'm not a particular fan because it doesn't overall in that same study. Sunitinib had almost the same data, doubled the progression-free response rate from around a little over 5 months to around 11 months. The overall, in that same study with everolimus, the overall response rate of the tumor shrinking was 4%. So, it's in, I'd say we have a lot of therapies. I liken it to, we have a quiver with arrows, and we have to pick the various options. We pull the arrow out of the quiver and fire it at the tumor at the right time. So it's one of the arrows in our quiver, but when you have capecitabine temozolomide that has a response rate of 40+%, Lutathera, showing response rates and improved progression-free survival, we tend to fire those arrows maybe sooner, and everolimus is one of the later arrows, at least in our viewpoint. And I mentioned the nab-sirolimus trial, which we think is a better drug. Nanoparticle albumin-bound sirolimus, which is another mTOR inhibitor, we think gets into tumor cells better. It gets into the tumor cells better. That's what it's a little. The nab-sirolimus paclitaxel is a Abraxane. That drug was approved for breast cancer and others. Has that same kind of chemistry. It puts paclitaxel into solution better, gets better drug delivery into the cells. So we think that, but if you've been on everolimus, you cannot go in the nab-sirolimus trial. So, you know, it's important, and I'm sure we'll hear more about it, but you understand the trials. You also understand that the trials have inclusion-exclusion criteria. So we try to at least offer nab-sirolimus as a trial before we put somebody on everolimus.
How do you spell that?
Nab-sirolimus, Nabsirolimus. It's local company in San Diego, Addy Biosciences. But we have that trial up at Hoag, so you can't have been on everolimus.
So we'll discuss
Not that I feel
about.
strongly, I'm a surgeon.
No, so we always encourage patients to participate in a trial, but a trial is a trial. The drug might work, and the drug might not work. So it's really important to have that discussion. What is the available option, standard of care option, which has already been through those rigors of trials and have shown that it benefits. So I think everolimus is a good option. Currently in our field, the debate is should we use it as a second line or a third line or fourth line, and I feel options are always great for our patients. We come from an era where we didn't have any options, so now multiple options. So it's fantastic. All right, I think we will take one last question before the lunch, or can we do one? Oh, okay, perfect. And this is regarding PRRTs and toxicities. What factors increases the risk of PRRT, I guess, toxicities, and any comment about small bowel obstruction after PRRT and other risk factors? I think we all do a lot of PRRT.
Yeah,
How
well, you
about
Dr. Chauhan, you answer that.
Well, so PRRT is probably one of the strongest arrows in our armamentarium, but it's also it's a radiopharmaceuticals. It's a drug that can have lasting impact on your bone marrow, especially. So there is a non-0% risk of long-term bone marrow side effects. The big ones are MDS, myelodysplastic syndrome, or leukemias. Now, fortunately for us, that risk is hovering around 1 to 2% as of now. And we have a lot of follow-up data from NETTER-1 and previously from European Erasmus data set, almost spanning 15, 20 years. That risk is 1 to 2%. Again, so if we are treating a relatively younger patient who has several decades to go, this is a significant risk. So you need to always explain that to the patient as compared to somebody we are treating 60 years old. The benefit might far outweigh the risk. So that's one factor. Regarding there is concern for renal or kidney toxicity, and that's have largely been resolved. I've personally treated over 300 patients with PRRT since FDA approval. I've not really seen, none of my patients ever gotten into dialysis post standard of care PRRT, the Lutathera. So it's relatively safe, and now we have a couple of publications suggesting that it can be safely done even with mild to moderate renal compromise. Third issue used to be thought hepatotoxicity, and that has also not panned out to be true. Mild elevation liver enzymes have been shown that it's not a contraindication from real world data. Regarding specifically small bowel obstruction, we are recognizing that some patients can get into small bowel obstruction. This is true for patients who have what we call peritoneal carcinomatosis. So a lot of disease around the bowels, sandwiching the bowels. So when Lutathera starts working, any radiation-based cancer cell death leads to first inflammation and swelling. So if Lutathera is working, it will swell up the bowels and the tumors around the bowels, and there's a risk of it causing an obstruction. It's a smaller risk, but it is definitely a risk. So many centers have now started doing a short course of steroids. We usually do Medrol dose back. ENET's, European Neuroendocrine Tumor Society, has a formal dosing guidelines as well. So about a week of steroids usually can bypass some of these complications, reduce the inflammation. I'm curious to see what our colleagues here do. Dr. Malucha, you deal with a lot of omental caking and really bad cases. So what's yours?
Well, I think the surgeons are going to agree. So our program tends to be really surgically heavy. So we probably have the largest series of operating on people with the complications of PRRT, and it is very difficult. It increases your complication rate, and I think it significantly impacts your recovery, and probably there are a lot of intraoperative issues that we almost regret. So I would say that I would be curious on what the other surgeons think. I think where we are opinionated is when someone presents with a small bowel primary, not necessarily peritoneal disease like you're describing, which is going to be complicated no matter what, a small bowel primary with metastatic disease, and they treat the stage instead of the grade, and that we have a very low threshold of operating on those people to remove the primary and or do a cytoreduction of greater than 70% in hopes of then palliating or diminishing the risks associated with putting some of these other therapies on later on in the disease process. So that is the importance of the multidisciplinary team and us all being complementary, because if you have one person saying, oh, because of multi-organ site involvement, I believe that PRRT, and it's a great technique, we are moving it up the chain, and there are patients where you use it much earlier on, but that is when you're doing it hoping that you never have to go back in. And then the peritoneal disease is always going to be complicated, whether or not regardless of what treatment you could give, you could have a complication of chemotherapy, and you wind up having to go in and operate, and it makes the operation that much harder. So that in general, if you have a complication of PRRT that requires an operation and you have peritoneal involvement, that makes an already difficult situation very difficult, and it's a huge problem.
That's one setting. I'm slowly moving towards early surgical debulking, follow-up in PRRT, because of the risk of obstruction, perforations, and things like
You guys heard it here, right?
All right. Okay. I think in the interest of time, we all need to eat and nourish. So we'll take a little break, but we have two wonderful junior executive members of NCAN. I'd like to invite, please, a round of applause.
Hello, it's gonna be lunchtime. There's gonna be a mahi-mahi. If you don't know what that is, it's a very colorful fish. And there's chicken, and if you don't know what chicken is, I don't know what to tell you.
What will the vegetarian folks?
There's a bunch of vegetables.
Thank